Good morning, everyone, and welcome to another Thyroid by MDS webinar. My name is Eyal Robenstock, and I'll be today's host. I'm delighted to present Dr. Anna Sawka and Dr. Katy Roberts as today's speakers. Before I start, I want to remind you to tune in to Voices of Wisdom, our podcast dedicated to medical professionals presenting insights and research in the field of thyroid cancer. And I am happy to congratulate Mark Erkin for his birthday today, the founder and the medical advisor of the Thank Foundation, which we all enjoy, including today's session. So first, we'll have Dr. Sawka present her research, followed by Dr. Katy Roberts, who will be a discussant. Dr. Sawka is a well-known thyroid expert who really needs no introduction. She's an endocrinologist, a clinician scientist, MD, PhD, and associate professor at the University of Toronto. Dr. Sawka received her medical degree at the University of Manitoba, completed residency and later fellowship in endocrinology at the Mayo Clinic. She then completed a PhD at McMaster University and received multiple awards and research grants during her career, and she serves as the editor-in-chief of the leading journal Thyroid. Following her presentation, we'll be joined by Dr. Roberts. She holds a doctorate degree in health education from Columbia University, as well as both Master of Public Health degree and Master of Science degree from Columbia University. Her work focuses on quality of life, health promotion, cancer prevention, control, and survivorship. She's been an adjunct professor in the Department of Health Studies and Applied Education Psychology at Teachers College, Columbia University for over 20 years. Thank you both for joining us, and Dr. Sawka, the stage is yours.
Okay, so I'm going to be discussing article that our group had published this year in Thyroid, and it's on decision regret after choosing surgery or active surveillance for small or risk papillary thyroid cancer. And I'll give you a little extra sort of background on the work as well. Those are my financial disclosures. And this article was published in Thyroid, but I had no role whatsoever in the peer review process and was blinded to it. Another editor handled it. So this is the paper, and we now have these QR codes. So the paper is available free online, and if anyone's interested in downloading it, you can just scan the QR code and it'll take you to the Thyroid website. So we're going to talk about this ongoing prospective cohort study of patients with small, low-risk papillary thyroid cancer, where we've been offering the choice of surgery or active surveillance. And this is a one-year follow-up, patient-reported outcome follow-up study. So we'll talk about the response rate to this, the patient questionnaire. We'll also give a little bit of the clinical outcomes at that time point. The study is still ongoing for longer-term follow-up outcomes. We'll talk about decision regret. And we'll talk about it relative to what patients chose, and then adjusted as well for age, sex, follow-up duration, as well as whether they crossed over from active surveillance to surgery. And then we'll talk about some secondary patient-reported outcomes, including quality of life, mood, body image, and some discussion of strengths and limitations, and Dr. Roberts will kind of elaborate on that. So a little bit of background. So the fundamental components of active surveillance of small low-risk papillary thyroid cancer are to avoid or defer initial treatment, which is a standard of care would be surgery. And so the disease is closely monitored with clinical assessments and diagnostic tests, the foundation of which is serial neck ultrasounds. And there are predefined progression criteria. So it's not a do-nothing approach. There's an agreement with the patient that if the disease were to progress by predefined criteria, then salvage therapy or with curative intent would be offered. And in our case, that what's offered is surgery is recommended. This was, of course, first studied in micropapillary thyroid carcinoma by Dr. Miyachi et al. From Kuma Hospital, who initiated it in 1993, subsequently started in 1995 by Dr. Sugitani in Japan, and now there's studies from throughout the world. In our study, we went a little beyond the microcarcinomas to larger tumors. Now, this is the 2015 American Thyroid Association guidelines, and essentially there was no specific recommendation on active surveillance, but in the text there was a comment that for very low-risk tumors, papillary microcarcinomas without evident metastases or local invasion, that active surveillance could be considered. And I understand from the recent discussions at the ATA meeting that there'll be more on that in the upcoming guidelines. Now, the American Association of Endocrine Surgeons in 2020 put out a clinical practice guideline, and they were a little more forthright in terms of a formal recommendation, and indicated an active surveillance protocol for papillary thyroid microcarcinoma, so papillary carcinoma 1 centimeter or smaller, may be appropriate for carefully selected, informed, compliant patients. Again, we'll have to stay tuned for the ATA guidelines. Now, in terms of general features of papillary thyroid cancer that may make it more amenable to active surveillance, and this is on the assumption that the patient wants it. If the patient doesn't want active surveillance and wants standard of care treatment, surgical treatment or other treatment, then of course, this is not appropriate. So you need a consenting adult, and they need to understand the implications of the follow-up procedure, as well as the fact that, surgery would be recommended or treatment would be recommended if progression criteria are met. One needs a small papillary thyroid cancer, or in our case, we also included FNA suspicious for papillary thyroid cancer confined to the thyroid. So patients who do not have evidence of extrathyroidal extension on imaging, no nodal or distant metastases, where their tumor is easily visualized on the ultrasound and can be serially followed in terms of its size and other characteristics. Also, the location is important, and I won't go into a lot of detail. Dr. Miyachi's published a lot on this, but not in a high-risk location with respect to invasion of the trachea or recurrent laryngeal nerve. So why did we start an active surveillance study? And this really was an active surveillance decision-making study in Toronto. Well, in Canada, there had been rising incidence of thyroid cancer. This was largely driven by small, low-risk papillary thyroid cancer, more so in women than men. And you can see some epidemiologic data till about just over 2010. And here you see also, this was a map of Canada, and Ontario had really the highest incidence of thyroid cancer in women in the country by a pretty substantial margin. More so in Toronto, the incidence of thyroid cancer was 2.5 to 2.8 times that of other major Canadian cities. So we were diagnosing a lot of patients, many of whom had small low-risk papillary thyroid cancer. And so the question arose, is there anything we can do to de-escalate the treatment and try to avoid over-treatment? So this is the methods. Now, this is part of a sort of series of studies in terms of a larger kind of project. So we called it very low risk papillary thyroid cancer. That term has been used in a number of ways in the literature, but in our case, it was essentially T1 clinical N0 papillary thyroid cancer. So less than 2 centimeters maximal diameter. And our study started off as really a decision-making study. We've reported in that original paper in the supplement the information we gave to patients. So everyone had standardized information about active surveillance or surgery. Everyone had to have a surgical consult who participated in the study. And really, we didn't want to change people's practices in terms of surgery. It was more so essentially seeing how often patients would choose active surveillance if they were given the choice to not have surgery. So that was sort of the first phase of the study. We published on that, and we did some research relating to kind of factors relating to the choice that I'll just briefly mention in another slide. And this is really the second phase, which was from the Canadian Cancer Society, where we evaluated decision regret at 1 year in the patients who chose active surveillance and patients who chose surgery, respectively. Now, when we designed phase 2, we really had no idea how often patients would choose active surveillance. So there wasn't a sort of a preset comparison sample size, and we needed to, we planned to describe it in each groups, and if there was sufficient numbers that we could actually do a comparison, then we would do so. And now this has evolved into a ongoing pan-Canadian very low-risk papillary thyroid cancer prospective study funded by Canadian Institute of Health Research and Canadian Cancer Society, which is involving multiple sites, long-term follow-up outcomes. And most of the patients who were enrolled in the original Toronto study actually have consented to participating in the multi-center study and continuing follow-up. So what was our inclusion criteria? Well, these were all adults, so age 18 years or older, untreated papillary thyroid cancer or suspicious for papillary thyroid cancer on biopsy. So we did mandate that everyone had to have a biopsy. Papillary thyroid cancer needed to be less than 2 centimeters in maximal diameter, and we repeated the imaging at our site. So the imaging was very standardized. There was some evolution in terms of the patients with other sort of thyroid, parathyroid diseases, and essentially we had patients who had, for example, mild primary hyperparathyroidism were interested in the study initially. They may not have necessarily been enrolled, but we actually made an amendment to allow patients who had other thyroid or parathyroid issues that did not have an absolute surgical indication to enroll in the study because of, a lot of patient interest, actually. Our exclusion criteria, so high-risk location in terms of the recurrent laryngeal nerve or trachea, evidence of metastatic disease, extrathyroidal extension, poorly differentiated or non-papillary thyroid cancer, someone who is medically unfit for surgery, because really they wouldn't be able to undergo crossover treatment if they progressed. Patients could not be pregnant at enrollment because we really wanted to have the baseline measurement at the time when they're not pregnant. However, after pregnancy, they certainly could enroll if they wanted active surveillance, or they could get pregnant during the course of the study, initiate active surveillance, and then be followed closely in the pregnancy. Again, the other absolute indication for thyroid or parathyroid surgery, and patients with severe comorbidity with life expectancy less than a year, primarily because there's really the need for intense active surveillance of a small papillary thyroid cancer in that context is questionable. So active surveillance, what was the protocol? So every 6 months for 2 years, this mirrored the Japanese protocol. Patients had ultrasound, blood work, and they had a clinical evaluation. They could change their mind at any time if they, even if their disease didn't progress, so they could let us know if they wanted surgery, or as RFA became available locally, they could, or if they traveled to get RFA, they could let us know that, and we'd still keep them in the study. They weren't discharged or from the study. They could do what they wanted, essentially, if they chose to. And salvage surgery was recommended if on 2 consecutive ultrasounds or papillary thyroid cancer grew more than 3 millimeters in maximal diameter. There was incident metastatic lymph nodes that were biopsy positive, extrathyroidal extension, which is a tricky thing to diagnose on ultrasound, but if there was suspicion, we recommended surgery. Concerning location growth, so if the tumor was maybe near the trachea, was growing in a way that we thought that there may be compromise, we recommended surgery, and incident distant metastatic papillary thyroid cancer should that occur. For the surgical group, we really wanted to keep this as a natural history study. So patients had standard of care treatment and follow-up. as per their treating physician. So we did not instruct patients or their doctors in terms of extent of thyroidectomy, radioiodine, TSH suppression, unless they happen to be our patients. And there was no specific follow-up procedure. We simply reviewed the charts, and we also surveyed patients. So in terms of the choice of disease management, it was really up to the patient. Again, every patient needed to see a surgeon at enrollment, and if they hadn't, they would be referred to a surgeon for formal surgical consultation, so they understood the type of surgery that would be recommended, as well as inherent risks and benefits. The questionnaires were sent out about a year after their enrollment, and there was some variability in terms of when they were received, because for some patients, this was actually in the course of the pandemic. So, really, it's not exactly 12 months when patients sent back questionnaires. Sometimes it would be they'd bring it in or do it at their follow-up. But roughly a year was the time point. So at that point, we ascertained treatment status, decision regret, which is a validated scale, a short scale. And the decision that was being examined was the choice of active surveillance or surgery, fear of disease progression, short form, hospital anxiety depression scale on mood, MD Anderson symptom inventory for thyroid cancer, and body image scale. And then we also verified all the clinical information by medical review. And for the active surveillance patients, we were actually following them ourselves. So we had the clinical data. And in terms of the statistical analyses, won't go into a lot, but we did descriptive analyses. And then, and we really grouped patients according to active surveillance, whether they chose active surveillance or surgery. We also did some secondary analyses where we examined if they switched over from active surveillance to surgery, if there was any difference in the patient-reported outcomes. And we did some linear regression analyses. The reason being, these were adjusted for age, sex, and follow-up duration, since the groups were choosing active surveillance were different than the patients who chose surgery in some key features, which I'll talk about. So this is results. And this is just a little bit of background. This was, I remember I said the first phase of this study was to find out how often patients chose active surveillance or surgery. And we found that about 3/4 of patients chose active surveillance over surgery if they were given the choice. And the demographic and clinical independent factors associated with choosing active surveillance included older patients, less education, and surgeon hospital affiliation outside of UHN. And part of the latter was probably a reflection of referral bias, in that patients who essentially refused surgery at another hospital, the surgeon would refer them to us and say, well, here you go. Here's someone to enroll because they don't want surgery anyways. And there's sometimes been patients just wanted surgery. They didn't bother coming to our hospital. So there was some referral bias reflected in that. Psychological independent predictors of choice. There was people who progressed, people who were fearful about their thyroid cancer progressing on baseline questionnaire. So this is before they chose surgery or active surveillance, were more likely to choose surgery. And in contrast, people who were fearful about taking thyroid medicine, particularly as a consequence of having a thyroid surgery, chose active surveillance more often. And then there was some coping features. So active coping style, a do something approach, was associated with choice of surgery. And there's more detail in the paper I just cited there. So what happened at 1 year? So this is a flow diagram showing the initial enrollment, how many we screened, et cetera. And then we had one patient die of unrelated cause in the active surveillance arm about 6 months after enrollment. It was an elderly person, and they actually died of pneumonia and were at that point in nursing home. So a lot of comorbidities unrelated to thyroid cancer. And that individual had not progressed. Again, it was other causes. But our response rate was actually pretty good. It was 95.5% for the people that were eligible at 1 year to receive the questionnaires, actually did participate in the 1 year follow-up. And you can see that the active surveillance in this sort of subgroup was chosen by 79% of patients. So most of these patients had chosen active surveillance. So in this 1-year patient-reported outcome analysis, we have a total of 191 patients. Active surveillance group had 151, surgery 40. And I just highlighted in red, there was some differences between the groups. So again, older patients were more likely to choose active surveillance. And their follow-up duration was pretty close, but there was some of this was timing of surgery. And median tumor size was a slightly bigger in the surgical group, although not enough to be really clinically significant, between 13 millimeters and 11 millimeters as median. Essentially, there was more detail in the paper, but these are sort of key features. Now, in terms of at the 1-year time point, how many patients in the active surveillance arm crossed over to active treatment? So 11 patients had crossed over. This was about 7%. 10 of these had surgery. One had radiofrequency ablation. Outside the study, the patient actually traveled out of country and had this done in another country. By patient choice, there was no progression of that disease in that case. And in terms of the reasons for crossover, 2 patients had tumor enlargement, so disease progression, and where surgery was recommended by the investigator. 9 patients simply changed their mind and decided to have surgery. In some cases, there was some anxiety related to the tumor or other factors that might have contributed to their personal choice. And there was, this is just sort of a post hoc secondary, but in terms of the patients who crossed over from active surveillance, they actually were more similar in age to the patients who had initial surgery, and the people who were continued with active surveillance, interestingly, were older. So older patients seem to continue and not change their mind. And, again, that requires further follow-up with time. But it was kind of an interesting factor. And there was no significant sex differences between the groups. So a lot of the patients who were changing their mind were actually younger. Now, in terms of the type of thyroid cancer treatment in patients who had active treatment, this is really reflective of sort of our local practice. And essentially, most of these patients had a hemithyroidectomy. Certainly, bilateral surgery, total thyroidectomy would be needed if there was multifocal bilateral disease. And in some cases, if the pathology was in some ways worrisome, as the first surgery, then a second stage, a completion thyroidectomy was done. But most of these people were actually had a hemithyroidectomy. Most of these people did not have any nodal dissection. So our rates really contrast quite dramatically, quite a bit lower than some of the studies from Asia where it's more commonly done. So a usual surgery was kind of hemithyroidectomy. In terms of follow-up, patients who had thyroid surgery were more likely to go on thyroid hormone treatment at follow-up. And radioiodine use, it was actually in a minority of patients. You can see there was a statistically significant difference, but it really was not very many patients. Most patients did not get radioiodine, and their TSHs were relatively comparable at the time point they filled out the questionnaire. Now, here's the, I guess, primary real outcome that we were interested in, and that was decision regret. And it was total score on this decision regret scale, which is scored on a scale of up to 100, when 100 is maximal regret and 0 is no regret. And essentially, a value of less than 25 is probably considered low regret. There's a systematic review that we cited on that. Essentially, decision regret was, on average, actually pretty low in both the active surveillance and surgical groups, and it really wasn't very different. Here we just have a secondary analysis where you can look at the patients who had crossed over from active surveillance to surgery, and it was a little bit higher. Again, the numbers here are small in terms of the number of patients who crossed over, so it's not really a statistically well-powered analysis, but it kind of gives you an idea. But we do know that actually decision reversal in general and decision-making literature is associated with decision regret. And so the question would be whether that may actually get better with time. So now remember, the people in the surgical arm were not exactly the same as the active surveillance arm. These were the patients who chose, and different patients chose different things. So we needed to adjust for some other factors. We adjusted for age, sex, and duration of follow-up. And so first of all, we looked at a decision regret adjusted by these factors, comparing active surveillance and surgery. And again, even when you had adjusted for those factors, there really wasn't a significant difference between the groups. And then when we compared according to whether they crossed over or not, actually, once you adjusted for these other factors, the patients who crossed over actually had more decision regret than the other groups. But again, this is sort of a post hoc secondary analysis, which is hypothesis generating. Now, in terms of their other patient-reported outcomes, we have already talked about the decision regret scale. And I've got in this table, the last two columns, the comparison of crude data and then the adjusted data. And there really wasn't a lot of difference between the groups. There was no significant difference between fear of disease progression, which was actually kind of a notable finding, because in the beginning, the patients who had more fear of disease progression were more likely to choose surgery. So what was going on there? Why were these not different? And we'll go into that in another slide. In terms of the hospital anxiety and hospital depression scores, again, the adjusted data, there wasn't really much difference than the unadjusted crude data. There was slightly more anxiety in the surgical group. Interestingly, with the MD Anderson symptom inventory, there was actually statistically significant, and again, this is secondary analysis, but there's symptom inventory. There's a symptom inventory, and then there's inventory on how this interferes, how much this interferes with life, and so patients in the surgical group actually reported more interference. Body image scale was not much different, except there was one question on a scar, and so in that particular question, of course, the patients with the surgical group had a little bit more complaint, but again, that's not unexpected because the other group didn't have a scar. Now, this symptom interference subscale I mentioned, so this is the kind of things that they're talking about: general activity, mood, work, relations with other people, walking, enjoyment of life. And you can see that the surgical group, there was, it was pretty consistent across these variables, that it was a little bit worse than the active surveillance group. Now, I talked about the fear of disease progression and so what was going on here? Because at baseline, we know the surgical groups shown in blue on this slide at baseline was much higher than the active surveillance group. And what we see is that actually the surgical group, after they had surgery, a lot of that fear of disease progression really resolved, and they essentially were at a similar level of fearing disease progression as patients who initially chose active surveillance and who weren't particularly worried about fear of their disease progression at the beginning. So in terms of our conclusions and just a bit of discussion, the key finding in the study is the 1-year level of decision regret was generally low in patients who chose active surveillance or surgery, respectively. And we really didn't see any significant difference between the groups, either in the crude data or adjusting for demographic factors and follow-up. There was really no significant difference in fear of disease progression at 1 year in patients who initially chose active surveillance or surgery. And that's actually in spite of the patients in the surgical group having worse fear of disease progression at baseline. So they improved more after surgery, and they actually came down to a comparable level of fear of disease progression as the active surveillance group at 1 year. There was some of this greater symptom interference with quality of life reported in the surgical group compared to active surveillance. And there's been other studies from Asia that have looked at that and kind of used different questionnaires, but seen sort of similar kind of findings. Exploratory analyses suggest that there may be greater decision regret at 1 year in patients who cross over from active surveillance to surgery. But again, this is just a 1-year time point, and their surgery was later. They had some decision reversal. So the question is, what happens to that with time? And we are looking at that. So in terms of the study strengths, It's a prospective study. There was relatively low loss to follow-up, and we had a really good response rate at that 1 year in spite of pandemic and everything. And participants had standardized written information on the options at the beginning. There was a high degree of participant engagement in the decision-making, which we've published in other papers. And the standardized AS protocol was followed in spite of challenges like the pandemic. And our limitations, well, of course, we didn't randomize patients. We gave them the choice. That was our whole point of doing the first study. So this is not a randomized controlled trial. The groups are not the same. And there are some confounders in considering the differences in quality of life in particular. So there's baseline differences between the study groups. Limited study size population. It's still a relatively small study. It was studied, these participants were studied in depth, but again, it's a small study. It's in a single center in a tertiary care setting, so it may not reflect other kinds of practice settings. Many of our participants were highly educated, and so this may not be generalizable to less educated patients. And this is a Canadian study in a publicly funded healthcare system, and this may not be also generalizable to other practice settings and other healthcare systems. So in terms of next steps, further research is needed on long-term clinical and patient-reported outcomes, and this is going on in our study, expanded to an ongoing pan-Canadian multi-center study, and our study findings do need to be verified in other study populations. This is our funding that I've mentioned. So initially started with Ontario provincial funding, then the Canadian Cancer Society funded this 1-year decision regret study, and then subsequent long-term study by Canadian Institute of Health Research and Canadian Cancer Society. And this is our list of, this is the initial list. It did actually expand a bit with the co-investigators and collaborators in the original Toronto study. That list is larger now in the Pan-Canadian study. And I just wanted to also mention the co-PI on this study is Dr. David Goldstein, head and neck surgeon, and our radiology lead is Dr. Sangeet Ghai. And that's all my slides. Thank you.
Okay. Thank you, Dr. Sawka. That was fascinating. Now we'll move to the discussion with Dr. Roberts. And after that, we'll have a Q&A session, and you're all invited to send your questions. There's a Q&A tab on the Zoom screen. Dr. Roberts, the stage is yours.
Okay, yeah. So good morning, everyone. Thank you so much, for Dr. Sawka, for your interesting and important study. So today I'm going to focus on decisional regret, why it matters, and why we should care about this construct. Before I begin, I want to disclose that I have no conflict of interest. So here's a quick overview. I will discuss decisional regret in general and how it varies across cancer types. I will also be reviewing contributing factors that I will be reviewing the highlights of the study. And then finally, I'm going to conclude with recommendations for clinical practice. So decisional regret has far-reaching consequences. Patients who experience regret often report reduced quality of life. There is an association between higher levels of regret and poorer mental health scores, including anxiety and depression. Regret can also lead to suboptimal treatment adherence, including not following prescribed treatments and missing scheduled follow-up appointments. It can also impair future decision-making, as patients who regret a current decision may actually fear making the wrong choice again in the future. So the prevalence of decisional regret does vary across cancer types and treatment modalities. For instance, higher regret rates are observed in prostate and some head and neck cancers, where treatment often significantly impacts quality of life through physical or functional changes. In contrast, lower regret rates have been shown in breast cancer patients, which also could be due to better established treatment protocols, decisional aids, and better communication practices. Age also plays a role in decisional regret. So older patients often face comorbidities and more challenging recoveries, which can amplify their regret. On the other hand, adolescents and young adults may experience higher levels of regret due to developmental factors, decision uncertainty, and challenges in understanding complex medical information. Of course, there is individual variation. Some patients, regardless of age, may be better supported, more resilient, and have better coping skills. But age is something to think about, and maybe we do need to have age-specific strategies, such as counseling or decision aids, to support these specific populations in making informed and confident decisions. So several factors contribute to higher rates of decisional regret. Poor physical health outcomes and unexpected or undesirable side effects from treatment may leave patients questioning their choice. Another factor is the reoccurrence of cancer, which can lead to feelings of regret if patients believe their initial choice was inadequate. Patients with higher level of anxiety, either at baseline or during the treatment decision process, may experience more regret. And anxiety can make it harder to feel confident about your choice. A lack of awareness of potential side effects during the decision-making process. So when patients feel they weren't fully informed or didn't understand the risk, they're more likely to experience regret later on. And dissatisfaction with the level of involvement in the decision-making process. Patients can feel that their decision about their treatment was made for them rather than with them, where they have the ownership of their choice. So on the other hand, lower levels of regret are seen in patients whose treatment aligns with their personal goals and values. Effective communication, the use of decision aids, and counseling can help to reduce uncertainty and build confidence. We want patients to feel informed and supported, which minimizes regret and improves satisfaction with care. So effective communication between patients and providers is important in reducing decisional regret, improving overall patient outcomes. One strategy is improving the delivery of information and emphasizing shared decision-making. This means that patients are fully informed about all available treatment options, including the risk, benefits, and potential outcomes, and that their values and preferences are incorporated into the decision-making process. In this study that we just heard about, participants who chose active surveillance were more fearful of surgery, whereas those who chose surgery were more fearful of the cancer itself. So understanding and recognizing patients' fears and addressing them through effective communication can help patients feel confident about their decisions. And we want to build rapport and trust. It's essential when patients feel that their concerns are heard and respected, they are more likely to feel confident in their treatment decision, even if the outcomes are not ideal. And we want to use decision aids and other communication tools. These can be very simple. So a decision aid could just be a pamphlet, or it could be more advanced, such as videos or apps where patients are provided with these clear, accessible information, and they're provided with support in weighing their options. Address barriers to communication, such as low health literacy and cultural and language differences. And finally, we want to foster a culture of patient-centered communication where patients feel comfortable expressing their concerns, asking questions, and actively participating in their care. So we'll go on to Dr. Sawka's wonderful study on decisional regret, which I think is extremely interesting and is needed. So we already heard the highlights, but it found no difference in decisional regret between the two groups. Regret was higher among patients who crossed over or switched from active surveillance to surgery, and surgery was associated with more body dissatisfaction and higher symptom burden. So as we heard, this study had several strengths. It is a prospective cohort study, and it had high participant response rate. The 96% is actually excellent. The results align with broader research on decisional regret and the burden of treatment. So patients who chose active surveillance were more fearful of surgery, while those who chose surgery were more fearful of the cancer itself, which is well documented. So some considerations or limitations which were also reviewed was the small sample of patients switching from active surveillance to surgery. So this limits that subgroup analysis and the ability to draw meaningful conclusions in this group. And this is actually the group of interest because as the study showed, this group had the most decisional regret. Generalizability may also be limited due to the highly educated study population. So these individuals were more likely to be informed from the start, which reduces decisional regret. And the study was conducted in Canada, where healthcare systems differ from other countries in terms of access, cost structures, and patient expectation. Additional measures such as the intolerance for uncertainty or decisional conflict scale might have been helpful in understanding their decision-making process at the time of the patient's initial choice. And additional time points might also have been helpful, such as at 3 months or 6 months, or even longer follow-ups, such as 3 years, which might be planned because it is an ongoing study. This way, we can see if decisional regret evolves over time. There is some evidence suggesting that post-treatment cognitive processes such as reframing our worldview or adapting it to accommodate the experience may contribute to reduced levels of decisional regret several months or even years after a decision. So for practical recommendations to reduce decisional regret, we need to focus on 3 areas: enhancing patient decision-making, improving communication, and providing post-treatment support. First, enhancing decision-making involves using tools like decision aids to clarify risk and benefits of different treatment options. These aids can be helpful in aligning decisions with personal preferences and values, making patients feel more confident in their choice. And actually, Dr. Sawka has done some research into decisional aids. We need to improve communication, which can include training providers in patient-centered communication strategies such as active listening and motivational interviewing. We want to encourage discussions about fears and expectations and preferences to ensure the patients feel heard and supported throughout. These discussions can reduce uncertainty and build trust. And we do want to provide post-treatment support, which can be helpful in reducing regret and could be helpful in reducing any of these crossovers. So providing emotional and psychological support through counseling or peer-supported groups and addressing concerns related to body image and physical recovery from surgery can improve satisfaction with treatment. So in conclusion, regret is a complex emotion, and we do need more insight into how it shapes patients' experiences and outcomes. Well-informed, patient-centered care is important in reducing decisional regret. By understanding patients' fears and goals and providing clear communication, education, and support, we can empower patients to make decisions that they feel comfortable about. This approach not only improves satisfaction, but also contributes to more positive long-term outcomes. Okay. Stop sharing.
Thank you, Dr. Roberts. Excellent presentation. And now we'll have some Q&A, and everyone's on board and listening can send their questions. My first question is to Dr. Sawka. At the end of the presentation, you had a very long list of centers and doctors participating in this study. And in my practice, I see it as the biggest challenge because every doctor explains things differently, endocrinologist versus surgeon, and various centers. It's not in the study, but in the way you felt the data and you saw things, how important was it? Who the patient interacted with?
Well, thank you. Thank you, Isle. So there was some, as I mentioned, the patients who were referred from outside doctors were actually more likely to choose active surveillance. And that's probably a reflection of referral bias, that patients who didn't want surgery were, the doctor didn't really have, the an active surveillance program, right? So they referred it to us. And so I think that that's already in there by who we saw. But the reality is that when you actually look at, the surgical, usual care surgical arm, the patients obviously they chose surgery, but they could choose also what surgeon they would have. It really wasn't that different. And I think that part of it is that this was all in the Greater Toronto area, sort of Southern Ontario, and many of the surgeons were, I think, probably trained at our institution. So there was sort of a similar philosophy about, extent of thyroidectomy, central attitudes to central nodal dissection. So really where it came in was the usual care surgical arm. Active surveillance patients all got, the same standard follow-up because we had to keep that centralized, in part due to the imaging. We wanted to reduce variability due to, different imaging techniques, and we wanted to make sure that we were following those patients. And the other thing is too, that they all needed to see a surgeon, but in our, so we didn't give them, for example, specific complication rates for surgeries because it really depended what surgery was being offered and what surgeon was doing it. But in our sort of pamphlet, we said, well, here's some questions you could ask your surgeon if you don't already know, and related to that. So they could that actually was helpful to patients because they could go back to their surgeon and get the personalized information. So I don't know if that's helpful, but it really wasn't a problem. It was very interesting to see how the mindset of the participating doctors, collaborating doctors, were actually very similar in terms of attitude to management of this disease.
So let's say you had endocrinologists and surgeons who are on board. So a follow-up question, what about the radiologists? Because sometimes we have patients, they have, I'm on board, the surgeon is on board with active surveillance, and they go to the radiologist and they tell them, this is still inside your neck, but you have cancer. Why didn't you go to surgery? And then more
Yes.
regret and more, and again, you need to explain everything. So again, how do we have many people in the picture, in the medical team? How do you see that?
Yes, great question. So it really depends when they're interacting with the radiologist. So the issue is that we were putting on, and this was, prior to the pandemic, we had these periodic symposia on sort of continuing medical education for local doctors involved in thyroid cancer care, including radiologists. And I remember there was a session where we actually talked about the ATA guidelines. So this was post-publication of the last ATA guidelines, and not needing to biopsy lesions less than a centimeter. And actually, one of the radiologists in the audience from a community hospital commented that, there's no way I'm going to stop. If it's suspicious, I'm going to biopsy it. And so the interesting thing that happens is that these patients may go to, so in our institution, these patients would often not be biopsied if they had a tumor less than the suspicious lesion less than a centimeter. They'd follow Thyroid's criteria. But they often, what'll happen is an endocrinologist in the community may refer to a community radiologist, a community ultrasound clinic, because as some endocrinologists do their own ultrasounds and biopsies and surgeons, but a lot of times they do refer to community radiologists. That patient will see the radiologist will decide to do the biopsy, and then the patient comes back to the endocrinologist and says, oh, now they have this positive diagnosis. The endocrinologist refers the patient to the surgeon. The surgeon says, well, I never would have biopsied this. The surgeon is then referred to us saying, well, my surgeon says he never would have biopsied this, but I had this biopsy and I don't really want surgery. So now the thing is, in
Obviously, it
terms
plays
of,
a
so
role.
that's the
Yeah.
beginning. That's the
Yeah.
beginning. And did this change over time? I don't know. Like I think some
Yeah.
people may not change. That's the reality. But what happened in our institution was, this is where we have to credit Dr. Sangeet Ghai, and he's written 2 radiology papers now, in terms of active surveillance methodology for from a radiologist perspective. And so he taught the radiologists locally about how do you do this active surveillance? How do you, so it's really been, sort of enhanced at our institution by all the radiologists that are reading ultrasounds. They're very aware of this. They know what to look at. And we've also kind of expanded that to the Pan-Canadian study to other radiologists and other sort of centers that are participating. So hopefully that answers your question. It's kind of complicated.
Yeah, it is. It takes a village to do active surveillance. Yeah.
It does to some extent, yes.
Yeah.
Yes.
Yeah. Okay, now I have a question to Dr. Roberts, and it's a bit of a philosophical one. So in the past, everybody had surgery, everybody had the radioiodine, the patient had one option, and they did it and continued with their life. They didn't have anything to regret. They may be unhappy with the doctor, but they didn't have anything to blame themselves for an outcome. So sometimes I ask myself, I'm sure that medically we're doing good, but not by not sending everyone for surgery, but psychologically, sometimes I question psychologically if it's actually better. You're on mute. We don't hear you. Yeah.
Excellent question. This is why I was thinking, oh, it would be nice to actually look at a patient's intolerance of uncertainty or some kind of measure to determine if they actually have this higher fear of progression and will it lead to, more anxiety and decisional regret. Because in the past, you're right, they didn't have to think about it. It's like, okay, this is what I'm doing, and I didn't have a choice. And so I'm happy because the choice was made, and there actually wasn't a choice for me. But now that we have a choice, we actually really are concerned about the patients who have that higher anxiety, that higher fear of progression, and how do we mitigate that?
Yeah. What do you think of that question, Anna?
Yeah, I think we actually did look at decision regret in prior research related to radioiodine remnant ablation, actually, in low-risk papillary cancer patients. So I think there's other factors, as Catherine mentioned. If you've had complications or a bad outcome, then often there is that component of kind of worse decision regret. But I think that the reality is, I think there was a very wise statement by a patient he's currently in his 80s, and he was just, we've been following him for 7 years. His tumor has not grown, and he was about to leave, and was doing his yearly follow-up, and he turned around and he said to me, I it took me a while to sort of get around this and make this decision and think about it, but I'm really glad I did. And, I want to thank you for offering this program and giving people a choice. So there's that initial, kind of thinking about it, and it's variable with some patients, because some patients may have very strong feelings, they want surgery, they have very strong feelings, they want active surveillance. But for some people, it's like, yeah, there was a process, but then once they got through it, they're actually glad they did. And in the long run, he's doing well at 7 years, and actually is thankful that he had this opportunity.
Yeah, you also showed it in the study that the perceptions and approaches before surgery, before the decision, and later on was changed. The anxiety was lower. There was a previous study showing that before surgery, people worried about recurrence and mortality, and a year after, they worried about quality of life. So it changes during follow-up, right?
Yes, yes.
Yeah, and I would have loved to see, like, with that individual, like, when did that process change? When did he accept it? When did he, cognitively process? Was it like 1 month after? Was it 6 months after? Was it a year, or even 5 years? Like, when was that change?
So, Catherine, the 1 year time point was deliberate, because we wanted to make sure if anyone needed a completion thyroidectomy, for example, that everything was able to get done that needed to be done, that if they were started on thyroid medication, that there was time to stabilize that and optimize the levels. Like the TSHs were actually pretty good, so we wanted to make sure that everything was stabilized, they've recovered from their surgery before we asked them the question, because we didn't think it was fair. If you do it too early, then of course the surgical group is going to have more problems, both in the symptom standpoint from, the scars healing, etc. And also, they're still going through it. So you need to give them some time to reflect. So we thought 1 year was a reasonable time point. And, I think that we can see that that fear of disease progression was already down before. It might have been right after they had surgery. I don't know. But the thing is, this seemed like a good time to be reassessing that. And the other thing is, you wouldn't get a 95% response rate if you were serving people every 2 or 3 months. Like we wanted to get one good response rate.
But it would be interesting, because if we could pinpoint that
It
time,
would be interesting.
and we could provide like the support, like, okay, maybe that's exactly when we need to give them support, so they don't have that.
I think 1 year is an excellent time point, because they've already had an ultrasound, they have their thyroglobulin, they see if it's stable or not. So I think 1 year is it's a good time to check that. So we're reaching the end of the hour. I want to thank both our guests, Dr. Roberts and Dr. Sawka. It was fascinating. There's a lot more to discuss. We can have 1 more hour just discussing these topics. And thank you all for tuning in, and join us next week. Bye, all the best.
Thank you. Happy holidays.
Happy holidays.